My name is Tugunov Nazım John. I'm from Faculty of Dentistry, University of Hong Kong, and today I will be moderating today's session. Welcome everyone, and thank you very much for your contribution, and thank you for joining us today. Well, let me introduce Prof. Konstantin Ronkin from the United States, and today's presentation entitled "The Sleep Epidemic: The Role of Dentists in Prevention, Diagnosis, and Treatment Obstructive Sleep Apnea." Prof, thank you so much. Thank you for joining and thank you for your contribution. I think you can continue. You can start your presentation. Thank you so much.
Thank you. And I just want to make sure that everybody see the presentation, the screen, and they hear me, right?
Yeah, we can see your slides and we can hear you. Thank you.
Excellent, excellent. First of all, thank you for very much for the invitation to speak at this conference, and I'm grateful for this opportunity. Thank you very much. All right, so the sleep epidemic and the role of dentists in prevention, diagnosis, and treatment of obstructive sleep apnea. All right, how I can advance this? Hold on.
You can use the arrow keys.
All right. Do you see this slide, right? The obstructive sleep apnea is a common disorder among adults and children. In 2018, the American Center for Disease Control classified sleep disorders as a public health epidemic. Sleep disorders affecting people of all ages, men and women, almost everywhere, and it is silently killing us. Silently, we don't know about this. So a couple of numbers. 24% of men suffer from sleep apnea, and 9% of women at the age from 30 to 60 years old. And this is very, very conservative numbers. Why? Because 90% of people with obstructive sleep apnea not diagnosed. 90% of OSA not diagnosed. And 75% of them have a severe sleep apnea. Severe sleep apnea. And let me go back. Kids also have sleep disorders. Around 11-12% kids snore, and traditionally reported to range between 1 and 5%, with a risk prevalence occurring, with the peak prevalence occurring at age of between 2 and 8 years of age. All right, kids also have a sleep issue. So perhaps better topic for my presentation would be not a sleep epidemic rather than sleep pandemic. It's everywhere, and it's killing us more than COVID and other health issue. Obstructive sleep apnea is characterized by recurring narrowing or collapse of the pharyngeal airway during sleep, resulting in substantially reduced or complete cessation of airflow, despite the ongoing breathing effort. Loud snoring is typical feature of obstructive sleep apnea, and in most cases, the culmination of respiratory events is associated with brief awakening from sleep arousal. Obstructive sleep apnea is associated with a narrow airway with major comorbidities, including the daytime sleepiness, impaired cognition, and poor quality of life. And increased motor vehicle accidents. Patients with obstructive sleep apnea are 3 to 15 times more likely to be involved in a car accidents. There is strong evidence to suggest that obstructive sleep apnea is a dependent risk factor for severe cardiovascular outcomes. According to the literature, comorbidities of OSA with cardiovascular disease is 40%. With arrhythmia, 50%, drug-resistant hypertension, 75%, cerebral accident, 84%, like strokes, right? Heart attack, 50%, diabetes type 2, 75%, fibromyalgia, 80%, impotence, 50%, kidney disease, 50%. And for us, it's very important, TMD, temporomandibular joint disorder, 75% of correlation. It's huge, right? Huge. 75%, and according to the literature, between 75 and 95% of patients with TMD have obstructive sleep apnea. And 75 to 80% of patients with OSA have a temporomandibular joint disorder. And this is a tons of literature. For example, this article saying that 75% patients with TMD had a clinical signs saying that they had breathing problems during the night. This study, 75% patients with OSA suffered from chronic pain related to TMD. Another study, this study, even like more, 95% OSA patients had a TMD. So it's many other articles supported this percentage. So that's why the rule number one, at least in our clinics, all TMD patients should be screened for obstructive sleep apnea. And until proven otherwise, they suspected patients with OSA. So until we proven that they don't have it, obstructive sleep apnea, we treating them as a patients not only with a TMD issue, but also with a sleep apnea issue. The life expectancy probability of patients with untreated sleep apnea diseases as the stage of apnea deteriorates, it's getting worse and worse. According to this study, the probability of 20 years life expectancy of the patients with untreated mild sleep apnea is 95%. But while the patient with untreated severe apnea have a 20 years life expectancies of only 58%, almost half of the patients not going to survive in 20 years. According to the literature, also, on average, the life expectancy of those suffering from obstructive sleep apnea, let me put this slide, obstructive sleep apnea is 20% less than that of healthy individuals. For example, if the average life expectancy of people in United States is 80 years, then the average life expectancy among OSA patients is only about like 64 years. So a huge difference, right? So what we can do, first of all, to identify. Remember, 90% of sleep apnea is not diagnosed. And the best place to do this is dental office. Dental office. And this is statistics. Almost 75% of Canadians visit a dentist in 2009. 61% of Americans visited dentist in 2011. 91% of children in Canada visited dentist. 81% of children in America visited the dentist. So 84% of teens in Canada visited dentists in 2011. So it means that it's so many patients coming to us, and we have opportunity to diagnose, to detect the obstructive sleep apnea. And you will see why it's also important for the dentists to do this. Who we should screen? First of all, it is necessary to take into consideration three main risk factors that increase the likelihood of obstructive sleep apnea: obesity, male sex, and aging. Okay, when we're talking about obesity, deposition of fat around the pharyngeal airway increase the collapsibility of the pharyngeal airway. Fat deposition around the abdominal leads to reduction of the functional residual capacity. Lung volumes associated with diminished oxygen stores, which would contribute to ventilatory control and stability, like we call this high loop gain. Male sex, increased fat deposition around the pharyngeal airway. The majority of the available data suggest that the male sex has a high predisposition to obstructive sleep apnea. Increased length and collapsibility of the pharyngeal airway, and also to compare to the women, hormonal differences between men and women. All these factors kind of make the male more prone to the sleep apnea. That's why the percentage-wise is twice more male suffer from sleep apnea. And aging. The frequency of the sleep apnea increases with the aging and reaches the plateau after 65 years. And when we see in our patients, we can notice like dental signs which correlated with sleep apnea. And that's why we see the high correlation between malocclusion, TMD issues, and sleep apnea. We see patients with retrognathia, high palate, narrowed arches, and enlarged palatal tonsils, adenoids. Normally, adenoids and tonsils start to get smaller at age of 5, and by age of 12, they almost disappear. It's supposed to be in normal life, but we can see a lot of kids, a lot of teenagers and adults with adenoids and tonsils, enlarged tonsils, and this is a reason for this, and it will make them to breathe through their mouth. Not then we have a problem with the nasal breathing with these individuals, and they prompt to have a sleep apnea. We can see patients with a long, soft palate and uvula. This is another sign. Crowding of the teeth, overbite, distal position of the mandibular, broxers, clenchers, oversized and scalloped tongue. Oversized tongue occupies room in the oral pharynx. And statistically, 70% patients with OSA have a scalloped tongue. We just need to differentiate them from like other reasons for scalloped tongue. For example, small oral cavity or problems with thyroid gland. We will talk about this. This is a study shows that the tongue scalloping is predictive of sleep pathology, confirmed by PSG. "75% of GERD patients have OSA. As a result, we see patients with acid erosion like this or like this, right? What are we doing? We are restoring them using like composite bondings or using veneers. In many cases, we're not asking, we're not checking for the sleep disorder. But again, 75% of these patients could have sleep apnea issues. Symptoms, signs and symptoms. Daytime sleepiness. Headaches, especially in the morning. Frequent awakening. Hypoxia during the night. High level of CO2 and acidosis. Overweight. We talk about overweight already. Metabolic syndrome. Respiratory stops while sleeping. If the bed partner can tell us that this type of things happen. And snoring. and snoring. Snore is not normal. It's already some disorder. It's not normal sleep. Hyperthyroidism. 11% of patients with the OSA have a hyperthyroidism. Again, as a result, we can see the scalloped tongue when you don't have enough of thyroxine or triiodtyronin in a patient system. So we need to screen patients with all these risk factors: weight gain, obesity, men's sex, age, family predisposition, alcohol and sedatives, narrowing of the upper respiratory tract, bite pathology and temporomandibular joint disorder, smoking, endocrine diseases and metabolic disorders, and other. So it's huge group of patients we supposed to screen for the obstructive sleep apnea. Dentists can play major role in preventing and development of obstructive sleep apnea. Timely orthodontic development of the cranial skeleton, jaws, and airway. This is what we can do. Orthodontic treatment without permanent teeth extraction. Establishing the neuromuscular position, the physiological position of the lower jaw for any dental treatment, which will result to enlarge the volume of the oral cavity, make more room for the tongue. And if we're doing this, the airway will be open, more open, all right? Because most of us have a back distal position of the lower jaw. And most of the pathology, at least in our part of the continent, we have a class 2, division 1 or division 2, but we have a class 2 distal position of the lower jaw. When the jaw goes back, it also goes up. As a result, we have a very small oral cavity, and the tongue doesn't have enough room. And the tongue can go where? It can go only downward, and we can see the double, triple chin, especially like when the person doesn't have a extra weight, but still have a double chin. This is tongue. Tongue doesn't have enough room. And also tongue goes backward and close airway or make it smaller. So that's why when we treat patients, doesn't matter for what, we can treat, we can do just single restoration or multiple restoration or full mouth reconstruction. It needs to be done in physiological, restored position of the lower jaw. And normalizing nasal breathing is very important because the mouth breathers have a very narrow arches, very high palate, and when we try to treat them, it works against us. So normalizing nasal breathing is very important. Why I'm a dentist, why I'm talking about this? Why it's not ENT? Because when you send kids with adenoids to ENT, most often, very often, I see them back and ENT doctor just saying, okay, so let's wait, it will go away. But the problem is, like I said, by age of 12, probably it will go away if we remove the cause of this. But for all this time, for 12 years, the kid will suffer, and it will make the jaw very small, oral cavity very small, malocclusion, all this stuff. And then we're dealing with sleep apnea issues, and maybe in the future TMD issues for these kids. So nasal breathing is very important. This is our goal, to kind of normalize the nasal breathing for these patients, to prevent TMD in the future. All right, now we're moving in treatment, and obviously dentists play a huge role in a treatment of OSA. So, and historically, the sleep doctors is like, mostly it's like cardiologists, pulmonologists, all this type of doctors, and realize that sleep apnea, especially obstructive sleep apnea, related to the oral cavity, related to the position of the lower joint, development of all cranial skeleton. The gold standard for OSA treatment remains CPAP. This therapy involves delivery of pressurized air to the upper airway during sleep. Pressurized air acts as a splint open the upper airway, preventing it from collapsing during sleep. Oral appliances are the leading device alternative to CPAP therapy. Mandibular advanced devices, MAD, open the airway by moving the mandibular forward. Tongue moves forward with the mandibular. It increases genioglossus muscle activity to open upper airway, increase the activity of pharyngeal constrictor muscles to open middle airway, and the more than 60% of patients keep using MAD after 10 years. The study was done to support this statement. More than 60%. Just remember this number, because when we're talking about efficiency of the appliances compared to the CPAP, we can see that it's pretty equal. So this study was done before the study. So let me say that the action of mandibular mandibular and advancement results in increase in pharyngeal airway space and reduces airway collapsibility. Oral appliances have a demonstrated role in improving snoring, obstructive apneas, hypopneas, and oxygen desaturation measures. Oral appliances also have a demonstrated benefit on health outcome measures such as daytime sleepiness or blood pressure. All right. So this is what oral appliances can do. Now, go back to this study. According to the study, over a third of patients will show a complete response to oral appliance therapy with a reduction of AHI less than 5, meaning it's like complete remission of sleep apnea. Another third had a 50% reduction in AHI. And medical professionals, they consider this as a success of the treatment. And the last third will not achieve 50% of reduction of AHI. So this is kind of failure. So 2/3 we can consider as a successful treatment, right? While the efficacy of CPAP is generally high, in the real world, long-term health effects of CPAP are likely to be compromised by low compliance of the patients and suboptimal hours of treatment use. CPAP has a high efficacy, low adherence. Oral appliances have a moderate efficacy, high adherence. As a result, in overall equivalent, we have a equivalent treatment effectiveness of oral appliances and CPAP. And that's why it's very important for us to use oral appliances. And it's so many of them. Last time when I checked, I found like 140 plus oral appliances. They're all different. It's like monoblocks and 2 plates connected with some sort of mechanism. As other variations include the range of degree of advancement and lateral movement, vertical opening, fabrication material, and the amount of occlusal coverage. So it's not like one device for every single patient. It's like different devices and they have their own indications to use. Mostly we use oral appliances to treat mild to moderate obstructive sleep apnea, but also severe sleep apnea for the patients who can't tolerate to CPAP therapy. Mandibular advancement devices effective in reducing the frequency and duration of episodes of complete or partial respiratory arrests, respiratory effort-related arousals, snoring, increase in the degree of tissue oxygenation during sleep, improve side effects of the sleep apnea. But the biggest challenge with med treatment, and not only med treatment, and other treatment. We're using now other modalities, other intraoral modalities like DNA or Vivas appliances. And the key point here to find the optimal mandibular position for the med fabrication. This is the key. This is the most important thing, because on one side, we need to move the lower jaw in a position to maximum for the maximum opening of the airway. But also, we need to take in consideration the condition of the temporomandibular joint and muscles. We don't want to move too far forward to stretch too much muscles and move the head of the joint too much down and forward, right? So, most data suggested to advance lower jaw from 25 to 75% from maximum protrusion. Traditionally, dentists use the George gauge or other gauges to establish the mandibular position for med fabrication. The problem is that some publications suggested that to use George gauge to establish mandibular position for the oral appliance fabrications, worsening of the AHI. Also, we can see a rotation in the cervical spine, hypertonicity of the masseter muscles, bite changes, cervical spinal deformities. So that's why the second best technology available, which can help establish the mandibular position in the at least sagittal plane, by titration of the lower jaw position while the patient is taking PSG test during the sleep, right? So we can remotely to use this device to move incrementally lower jaw forward while patient sleeping. This device called Matrix. It's allow us to find an optimal mandibular position in the sagittal plane according to the PSG data. And especially medical professionals, they think that is like golden method to find the optimal position of the lower jaw. And it is. And it is good technology. It is good technology. But we use neuromuscular method of determining the physiological position of the lower jaw to treat obstructive sleep apnea with the restoration of the muscle balance with the help of ultra-low frequency electroneurostimuation, electromyography of the chewing muscles, as well as electrokinesiography, allow us to move jaw in the most accurately position. Like this. This is a bite, and we can use this bite to fabricate the oral appliances. So, in 2017, we conducted the study to determine the effectiveness of the physiologic bite position of the lower jaw in comparison with the matrix position for the fabrication of the sleep appliances. And it was 32 subjects, 5 women, 27 men, with average age 49 years old, and the range was between 27 and 72. All subjects selected for this study were diagnosed with obstructive sleep apnea. So I'm not going to explain the whole study, but I will show you a couple of slides. As we see here, the physiological occlusal position in the point number 2, you can see number 2 here, right here. This is a physiologic occlusion what we determine, and all other like 3, 4, 5, 6, this is a different matrix position. Physiologic, this is matrix position, and then we took a EMG, and we found that the best matrix position is number 5 according to the EMG of the muscles. But the physiological position, this is position number 2, has a best position, best electromyography characterization, and we choose this position to fabricate oral appliances. The average physiologic bite position was 3.26 millimeters forward from the habitual trajectory. The average matrix position was 3.4 millimeters more forward than the average physiologic bite position. For this patient, for example, we can see this is 2 millimeters difference between physiologic bite position and the matrix, the best matrix position. So average is 3.4 according to this study. It's 2 conclusions of this study. The first one, the average, this study confirms that using the described method, neuromuscular method of physiological bite registration allows for the reduction of the protrusion of the lower jaw during the treatment of OSA with med appliances. According to the study, the average physiological bite position of the lower jaw was 3.4 millimeters distal to the matrix position. And second, the physiologic bite position is an effective way to determine the position of the lower jaw for all planes for the successful treatment of obstructive sleep apnea. It is more comfortable position for muscles. The average EMG in the physiologic bite position was 59% lower than the best matrix position. So it's better for the muscles, and it doesn't need, we don't need to move the jaw too much forward. So like I said, according to the study, 3 millimeters more distal from the best matrix position. So in the conclusion, I have to say that we must take into consideration not only anatomy, but also physiology of the whole body when we are treating obstructive sleep apnea patients. Thank you.
Thank you so much, Professor Ronkin, for your presentation. this topic is very important, and I kindly invite you to submit a paper in World Journal.
Good. Yeah, we'll work on this.
Thank you so much for your contribution
Thank you.
at our Congress. Thank you.
Yeah, thank you.